Hey all, I'm back with another podcast. This one is a continuation of the EFAST exam series, and we'll be on the lung. As I mentioned before, ultrasound is much more sensitive for picking up pneumothorax as well as pulmonary edemas, pneumonias, etc. than chest x-ray is. And it's much easier, much faster. Pretty much all trauma patients should be getting this done for them, as well as a lot of the medical patients that you may have. The probe choice, you can use any of them. I prefer the high frequency linear. I think most people prefer the high frequency linear. The curved linear as well as a phased array is also used. Most people do the long axis view, which is what's showing up here. You can also do the short axis, which would be across in this fashion, and you would be between the ribs. Make sure you move the probe. Don't just stay in, or don't just do those two apices. Make sure you move down the different levels so you don't miss anything. Consider even doing the axillary side. Anatomy. With the ultrasound, you're looking down. This is the skin. Then chest wall muscle, intercostal muscle. The pleural line here is showing up as one, but you actually have two. You have the parietal pleural and the visceral pleural that are up against each other and rub back and forth. And that's what gives you the comet tails and the sliding that you see. And of course, you'll see ribs and rib shadows if you're doing the long axis view. And here's a view. You can see this here is subcutaneous tissue up here. This is chest wall muscle. This is intercostal muscle. This is a rib shadow, rib shadow. This bright white line here is a pleura. And again, you just see one, but it's actually two, the parietal and visceral. And then down below here is the lung. If it was a better image, you could see A lines, which are normal, caused by reverberations of the ultrasound. And here is a video of pleural sliding, what it looks like. You can see the sliding back and forth. And you can see the little bright lights coming off of them a little bit. Those are called comet tails. This is a normal pleural sliding. This patient does not have a pneumothorax in this part of his lung anyway. Again, here's rib shadows. And here's pleural sliding in the short axis. And you can see the pleura here. You can again see the little bright lights coming off of it. Those are called comet tails. And these little white lines here, not the best showing up here, but those are A lines. Talk about M mode a little bit. M mode, the only time I use M mode is for documentation. If for whatever reason I don't get save an actual video, although I almost always do, then you can print out a picture of M mode and put on the chart as documentation. This is a normal M mode. This is called Sandy Beach Seashore Sign. This is chest wall up here. This down here is your lung. And this is normal. Why they call it, looks like a beach or seashore. Here is the barcode sign, and this is the sign of no pleural movement, possibly pneumothorax. You can't diagnose a pneumothorax unless you find a lung point, which we'll get into later. So just finding a barcode sign or finding pleural that's not moving doesn't necessarily diagnose a pneumothorax. You can rule out a pneumothorax with seeing the pleural sliding, but you can't diagnose it unless you find a lung point. So this looks like a barcode sign. Again, this is chest wall, this is lung, and there's no seashore pattern. Going back to here, you can see the difference between a what looks like a sandy beach versus a stratosphere or a barcode. And here is an example of no sliding. You can see the chest wall moving. You can see movement of the intercostal muscles, but there's no sliding here with the pleura. This line here is pleura. You can see it's not moving at all. So this doesn't necessarily rule in a pneumothorax. Different things can be causing it. Just a couple off the top of my head. Right mainstem intubation, if you're looking at the left side of the chest and it's not moving due to the right mainstem. COPD with bleb, pleurodesis, etc. And here is another example of no pleural sliding. You can see this pleural line is just staying there. Here's the rib, here's a rib, that's a rib shadow. And you can see that line is just staying, it's not sliding back and forth like you would see with a normal pleura. Talk about lung points. A lung point lets you excuse me, definitively diagnose a pneumothorax. You can see this lung point moving back and forth right here. But on this side there's no movement. And this is where the pneumothorax meets lung that's still working. And that's called a lung point, and it's a definitive diagnosis, 100% positive predictive value. And this will rule in a pneumothorax. That's all you have to see. Let's look at it one more time here. Another example of a lung point. You can see the lung comes all the way out to about right here, and it's sliding back and forth. That's normal lung, and this is the part that's part of the pneumothorax. And you can see the pleura, how it's sliding back and forth here, but not here. So in closing, just to review, if you see lung sliding, it will rule out pneumothorax, 99% positive predictive value. Lack of lung sliding doesn't necessarily mean it's a pneumothorax. Like I mentioned before, there's other things that can be causing it. If you're on the left side and you have a right mainstem, you have a COPD patient with bleb, had prior pleurodesis, infections, pneumonias, consolidations, can cause a lack of lung sliding. So obviously if you get a trauma patient in, and you have lack of lung sliding, you're pretty comfortable knowing that's going to be a pneumothorax. But if you have another patient, a medical patient, COPD, etc., and you find it, don't automatically think it's a pneumo, you might want to work that patient up a little bit more. A lung point rules in a pneumothorax, 100% positive predictive value. And that's one reason why you look all over the chest and not just the apices, although the vast majority of pneumothoraxes you pick up will be in the apices. And this concludes this podcast. I hope you'll enjoy it. If you like it, please subscribe and like.